welcome to Chautauqua Institution. This is the parlor of the Athenaeum Hotel, built in 1881, so there's been quite a few people sitting here over the years. My name is George Murphy. I run marketing at Chautauqua Institution. I know some of you had questioned, and I apologize, the program that a lot of you are holding, the blue program, talked about a program this afternoon on macular degeneration, and that program was printed last Saturday. Tragically, the speaker passed away Saturday afternoon. So we didn't have enough time, unfortunately. We changed it in the newspaper on the website, but unfortunately the topic today will not be that. You can see here Dr. Hansen has agreed to step in and talk about women's health and aging, so I'm sorry if there's any confusion on that. As most of you know, we have a fairly packed schedule. This morning we had a great talk on mobility, and Scott Giberson gave a great talk on policy. We'll talk about women's health at lunchtime today, and then this afternoon we have a little bit more on aging also with Dr. Lynn. So, we're Turner at 3:30 this afternoon also as we wrap up the day. I'd like to thank, though, Dr. Hansen and LECOM for helping us this week, and in particular making sure we had a good presentation here this afternoon. Dr. Hansen has graduated from the Lake Erie College of Osteopathic Medicine and is a specialist in internal medicine and geriatrics with the LECOM Institute for Successful Aging in Erie. She's Vice President of Acute Care Services and Quality Performance Improvement at Mill Creek Community Hospital and a Clinical Assistant Professor of Internal Medicine at LECOM. She earned her residency at MCH and her fellowship training in geriatric medicine at LECOM. She is board certified by the American College of Osteopathic Internists and possesses a certificate of added qualifications in geriatric medicine. She received her Master's of Science degree in medical education from LECOM. As is customary, as most of you know, at the end of Dr. Hansen's presentation, we'll take questions. There's a mic here right in the front that is open for anyone who would like to ask some questions. And one thing I noticed in this morning is if you could turn off your cell phones, we'd appreciate that. There was a couple little beeping going on, as most of you heard earlier this morning. Anyway, so that's the end of my introduction, and please welcome Dr. Hansen.
Thank you. Good afternoon. I'm pleased to be here today. In addition to the things in the introduction, there's a couple other things that I want you to know about me. Since I'm going to be talking about women's health and aging, I'm a geriatrician, and the majority of my practice tends to be female patients. Dr. Lynn is my counterpart in the office, and he has probably the majority of the male patients, though we both do see the opposite gender as well, so there's certainly no restrictions. There may be some things that I'm talking about this morning that may be a little generalizations. I hope not to offend anyone, certainly. And as you can see, I'm a female. I'm a physician, so that's not necessarily the typical. My husband is a stay-at-home dad, and I have two boys that he helps to raise at home. So we don't tend to follow all of the typical things. So while I'm commenting on things that may be more generalizable, it's certainly not a prejudice or anything like that I have, as evident by my own personal life and professional life. My oldest son is 11. When he was about 3 or 4 for Halloween, we were trying to figure out what he was going to be for Halloween, and I suggested that he dress up like a doctor. And he said, "No, Mommy, only girls are doctors." Because that was what he was used to. So my life is a little different, I guess, than some of the generalizations that we'll be making here today, though certainly all of the health impacts apply to myself as well as many others. So we're going to talk about what is a healthy woman, what do you define as a healthy woman, what does everybody else define as a healthy woman. We're going to talk a little bit about the history of women's health and where we are right now and where we're going in the future. We're also going to talk about some leading health issues for women. We're going to talk about some of the more common things today, some of the things that would affect a larger group of people, though there are certainly additional things that affect women differently than men that may just affect a smaller subset of folks. We're going to talk about risk factors to see if you're at risk yourself, and then what can we all do to make a difference in our health, male, female, whatever age we're at, what can we do to make a difference in our health so that we can all live to be healthy and happy. The World Health Organization defined health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmary. This is something that's very in line with our osteopathic principles and practices as well. As an osteopathic physician, we focus on the mind, body, and spirit, not just the body or not just a certain disease process, but really how they all intertwine as one. This is a picture of a healthy woman. Probably a lot of us would agree, somebody who looks to be very fit and healthy. She has a nice plate of vegetables there and is lifting a dumbbell. But there's other pictures that may be healthy women as well. And we see people in all different aspects of life, all different walks of life, who are healthy or healthy for themselves. So it may be that even though you have a disease, there's still other things that you can do to make the best of your health despite that disease or regardless of that disease, or take charge of those diseases and to be as well as we can for years to come. This talks about the women's important role in healthcare. So it says women hold the keys to medical care because they are the chief medical and chief operating officers of their individual households. Probably a lot of you would agree with that. But they really struggle to make their own health a priority. We need to help motivate women to prioritize their health and engage in lifestyle behaviors that can help reduce their own health risk. By committing to their health, these women will be better able to care for their families, serve as role models for their children, families, and friends. So women are the caregivers more often than men are for their children, for their spouses, for their parents, or for other people. So we also need to make sure that those women caregivers are taking care of themselves, because you can only provide great care to others if you yourself are healthy and well. There's different aspects of women's health. There's health issues that are specific to women. So those are the things that only women can encounter because like endometrial cancer, men don't have uteruses, so they can't have problems with their uteruses. You know, those are things that are specific to women. And then there's other health problems that are more common or more serious in women. So sometimes different disease processes affect women differently than men, and I'll give some examples of that. There's some things that cause women to die or have more problems or challenges from a disease than our male counterparts. And then there's health problems that are experienced differently by women because the characteristics or how they manifest themselves are different. And then the treatment options and the outcomes vary based on our gender as well. Health issues that are specific to women, those would be the diseases of the reproductive tract, so endometriosis, for example, fibroids, things that are related to pregnancy or health regarding pregnancy, either before, during, or after pregnancy. Women who have gestational diabetes are more prone to having diabetes later in life, and obviously that men can also get diabetes, but they don't have that as a potential risk factor. There's other female-specific cancers. Breast cancer, men can get breast cancer, certainly, but it's at a much lower rate than it is for women. Cervical cancer, uterine cancer, those are specific to women, obviously. There's sexual health concerns. Men have different sexual health concerns. Some of them may be similar, but because the anatomy is different, the hormones are different, there are differences. And then menopause affects women, though our male counterparts or people we spend a lot of our time with may have some secondary effects by us going through menopause, but they certainly don't go through it by themselves. Health problems more common among women, autoimmune diseases. I listed a couple examples here, multiple sclerosis and lupus. They can happen in men. Lupus occurs 9 out of 10 times in women, so 1 out of 10 would be men. So certainly those diseases can occur in men, but they're more common in women. Arthritis, especially rheumatoid arthritis, is more common in females. Osteoporosis is more common in females. It can also affect males, but it is more common in females. Urinary incontinence is something that can affect men and women, and because of the different anatomy of the genital urinary system, it affects us differently, and the treatments are different as well. Alzheimer's disease actually is more common in women, and part of that may be because women live longer. So as we get older, we just may be more prone to it, or we may have that diagnosis more often because we live longer. Depression is more common in women, and so is domestic violence. Now, some of these things we're not sure if the reason they're more common in women has something to do with physiology or microbiology or genetics, and there's ongoing research about that. Some people speculate that maybe those diagnoses, especially the last few on the list, maybe the last 4, are more common in women because women may be more forthcoming about those concerns. They might be more willing to talk about urinary incontinence issues. They might be more willing to talk about their memory problems or their mood than some of our male counterparts. Health problems experienced differently by women, that's heart disease, lung cancer, diabetes as some examples, and I'll go into the specifics in just a little bit. In terms of research, there's ongoing research that is looking at the way these different disease processes affect the different genders, and then what can we best do to treat the disease processes in response to that. In 1985, the Public Health Service Task Force on Women's Health Issues concluded that there really wasn't a lot of good information on women's health. A lot of females weren't participants in research studies, whether it was for medications or for other things. A lot of minorities and women weren't participants in those research studies. So starting in 1985, that kind of changed. And there's been several other policies and governmental movements and things that have occurred that now require women to be participants in research studies so that we can get as much information about women's health and how we can best treat women with diseases in addition to men. About 15 to 20 years ago, so that's prior to that 1985 or around that time, heart attacks were often misdiagnosed in women. Standard diagnostic tests didn't always fit women as well as they did men because of the research that was done more on males than on females. Screenings were considered unimportant, so cancer screenings that now we have realized how important they are, and other screenings for other disease processes that we know how important they weren't considered as important a couple of decades ago. And then there certainly wasn't good communication amongst healthcare providers, from the research community to the public, so that we couldn't all be good advocates for even our own health. Currently, it's a lot better. We're able to recognize that symptoms may present themselves or diseases may present themselves differently in women. The symptoms might be a little bit different, so we can still recognize, diagnose those patients more timely. We have better testing that can be gender specific depending on the need. And screenings and prevention have become extremely important. And there's a lot of push from patients, from insurance companies, from the government, from a lot of different angles, and certainly from healthcare providers for patients to undergo those screening tests as early and as frequently as necessary so we can try to catch diseases at an early stage and intervene accordingly. And the communication is also better. Patients are becoming very, very educated and are able to advocate for themselves much better, and information is more available to all of us. So it's a lot better than it was in the recent past. When we talk about women, certainly they're not the minority. Actually, the majority of the United States population, just by a little bit, 50.9% are female. So it's very important to talk about the differences, make sure that we're treating our patients appropriately. Over the course of their lifetimes, partially due because of the reproductive system and needs that women may have if they have children, when you're pregnant and you go through all of those perinatal visits, there's multiple healthcare encounters. Women use the healthcare system much more than their male peers. So if you add it up over a lifetime, women use healthcare much more than their male peers, maybe because of having babies, but maybe for other reasons as well. More women than men suffer from chronic conditions such as diabetes, asthma, hypertension, and they require ongoing care of those chronic diseases. And then women take more medications than men. 56% of women take prescription drugs on a regular basis, whereas our male counterparts, only 42% take medications on a regular basis. Life expectancy, I mentioned briefly that, and I think it's fairly common knowledge that women have a longer life expectancy than our male counterparts, but that difference is actually narrowing. So the gap used to be 8 years, and now it's down to 5 years. So there's some things either about the habits or the lifestyle that women are taking on, or maybe some things that men are improving in their lifestyle, or maybe some other things in the environment, social situations that are changing that are making making those life expectancy years actually getting closer in time. This is a graph that shows change in mortality for females. So red is bad. Red means that the mortality is worsening, and the light blue is that it's getting a little bit better. The dark blue is that it's getting a lot better. So we don't want to see a lot of red on the map, and this is changes from 1992 to 2006. And you can see there's a lot of red on the map that we wouldn't want to see. This is comparing males and females. So the top graph is the one that I just showed you with the women, and the bottom graph is the males. And you can see that there's a significantly different coloring pattern to those maps, where the males' health and mortality is increasing and improving, and females isn't nearly at the same rate and actually getting a little bit worse. So that's a concern. Good for our male counterparts, certainly, but it's a concern for the women. When we look at the leading causes of death, currently the leading causes of death for women are heart disease is the first one, cancer is second, followed by stroke, chronic lower respiratory diseases, Alzheimer's disease, unintentional injuries, diabetes, influenza, pneumonia, kidney disease, and then sepsis. Sepsis is a severe infection that affects the bloodstream and then multiple organs. And you can see by the numbers here, the top two, heart disease is 25%. So 1 in 4 women die from heart disease. Cancer is 22%, and then all of those other numbers below there are all in the single digits. So really, heart disease and cancer have a really significant impact on cause of death for women, and there's certainly a lot of different things we can do in our lifestyle to improve upon that or to have an impact on it. The red dress, I don't know if anyone's familiar with the red dress campaign from the American Heart Association. So this just shows that those dying from heart disease is much more significant than this is stroke, lung cancer, COPD, and then breast cancer. The table before had all of the cancers lumped together for that 22%, and this graph breaks them out by lung cancer and breast cancer as the leading cancer causes of death. Heart disease can kind of be a silent killer, especially in women. It is the #1 killer for men and women. 2/3 of women who suffer a heart attack don't actually make a full recovery. So that's a significant number, and that means that they don't recover in their ability to return to their prior activity level, to be able to do all the things that they did before. They probably have a huge, additional number of medications to take and other significant impacts on their lives. A study from the American Heart Association shows that they surveyed patients, they surveyed women to see if they recognized that heart disease had such an impact on, or potential impact on their mortality, and there has been a significant improvement in that. So in 1997, only 33% of women considered heart disease as something that could potentially kill them, but by 2006 that had improved to 50%, and it's probably even better now, partially because of that red dress campaign. For women who have their first heart attack 10 years later than men, and that's because of the estrogen and how it protects women for those who go through menopause without anything that prompts it to happen earlier, so somebody who has their ovaries intact, then women would have their first heart attack 10 years later than men. But women die from that first heart attack much more often than men do. So that first heart attack can have a much more significant impact on women. And if we look at the death rate from heart disease, it is declining, but it still remains, that 1 in 4 women will die from heart disease. Women have different symptoms than men, and women tend to be underdiagnosed and undertreated. Some of that is because of the way the plaque forms in the blood vessel walls. The risk factors for heart disease, genetic makeup, family history, gender, race, and aging process we don't have any influence on, but there certainly are a lot of things that we can influence. And it's estimated that 82% of unhealthy habits account for heart disease in women. So a lot of us women would be able to do something different in our lives that could impact or lessen the impact of heart disease on us. That's smoking, physical activity, depression, stress, diet, a high cholesterol diet, high blood pressure, diabetes, and obesity. All of those things can be influenced by our habits and the lifestyle choices that we make. As with men, women's most common heart attack symptom is chest pain, but we've all been educated, and there's ongoing education, that women don't always present with chest pain. Sometimes they have shortness of breath, nausea, they might have pain in their jaw, they might have pain in their back, they might have a stomach upset or something like that. So it doesn't always present as chest pain. We need to make sure that we're considering all of those things, and that you consider in yourself, your family, your friends, your loved ones, that if you have any of those symptoms and you just don't quite feel right, that you really should seek medical attention, because it could be something very significant like a heart attack. The classic saying, or you see the clutching your chest kind of thing, and sometimes people will say that an elephant's sitting on their chest, but for women, it's more like a mouse. It's something doesn't feel right. They're not quite sure how to describe it. Some women still have the elephant sensation, but for women, it's less likely that they'll be describing it that way, and it's more like something just not quite right. They can't put their finger on it, but they know something's not right. One of the reasons that it's hard to diagnose in women is the way that the blood vessels tend to clog. So a heart attack occurs because the blood vessels are getting clogged by plaque, and women and men both build up that plaque, but men tend to build up that plaque in a more irregular fashion. So it's lumpy, there's clumps of it, and when a clump occurs enough to make that blood vessel no longer have a passageway, that's when you have a heart attack. But for women, it's much more gradual process where the plaque builds up more evenly, and so it's gradual closing of their narrowing of that vessel that causes that heart attack. So the symptoms aren't always as intense, not as sudden. It's more of a gradual kind of process, and sometimes that makes it difficult for us to detect it in women, or for women to recognize in themselves that they should seek medical attention. Sometimes women tend to downplay their symptoms. They think, that indigestion or that funny feeling just is going to go away if I just wait a little bit longer, and then maybe an hour later it's still not gone. But if I just, try some 7-Up or ginger ale, maybe it'll go away, something like that. But that doesn't always happen. So we need to be alert. We need to listen to our bodies and listen to our instincts and seek medical attention for ourselves if we don't quite feel right. This says women don't always present with one big kink in the garden hose. It's more of that layering and slowly narrowing for women, which makes it harder to fix and harder to detect. In terms of cancer, so cancer is the second leading cause of death in women. Heart disease is the first. Cancer is the second. 22% of women die from cancer. And if we figure out what the top 3 cancers are in women that cause death, the first one is lung cancer, and it's actually increasing. Breast cancer is the second, and these are the ones that cause death. And then colorectal cancer is the third. So there's much more higher number of women who actually have breast cancer than lung cancer, but lung cancer is more deadly. This shows the probability of developing cancer. So of all sites, 1 in 3 women will develop cancer at some point in their lifetime. That's a lot. That's a lot of people in this room, 1 in 3. 1 in 8 will have breast cancer, and lung cancer or bronchus cancer is 1 in 16. But like I said, the lung cancer is more deadly than other forms of cancer and more deadly than breast cancer. This graph shows us over time, how are we doing in terms of cancer death. So over on the right-hand side is 1930. Over on the left-hand side is closer to now, 2005. And the different colors are the different types of cancer. The ones I want you to see the most is lung cancer, causing death, a significant increase. Significant increase over the last 50 years, most likely related to tobacco use and how that had become much more common amongst women. Breast cancer is decreasing. Uterine cancer is this blue line, significant reduction there as well, which is excellent to see. But certainly the lung cancer really has a significant impact, and a lot of lifestyle and behavior things we can do to affect that. Cancer screening is really a form of cancer prevention. Routine screening can be done for people for different types of cancer, but colon cancer, cervical cancer, breast cancer, there's routine screening for. There is not necessarily routine screening for lung cancer. There's kind of a push to do CT scans of the chest for people over the age of 70 who have had a significant smoking history, but it's not been well adopted yet by the payers because the number of CT scans and the amount of radiation hasn't proven to diagnose enough cancers yet to make that be a standard of care. So if somebody has symptoms, that's certainly something that we would do, but until there's symptoms right now, it's not being done on a regular basis. For people who have a colonoscopy or other screening for colorectal cancer, that can reduce the number of people who die from colorectal cancer by greater than 60%. That's significant, and that's because those polyps that they find on the colonoscopy are what turns into cancer. If they're able to remove them, it becomes therapeutic and not just diagnostic. A mammogram every 1 to 2 years can reduce the risk of dying from breast cancer by 20 to 25%. Controversy about a year or so ago about the frequency of mammograms, and everybody got in an uproar, and they changed the ways, and we can do them again. Rates of cervical cancer death dropped by 20 to 60% after screening programs began. That's significant, and the rate of cervical cancer death is actually very, very low because we do detect it at an early stage now, and there's multiple treatment options. For lung cancer, 80% of lung cancer is caused by smoking. So that's something that we can do to impact people who get lung cancer, the rate of lung cancer. Female smokers may be more susceptible to lung cancer than males. Still ongoing research about why that may be. Female non-smokers develop lung cancer more often than males as well. And again, there must be something within our being that makes it that way. And there's ongoing research about that. There's also differences in the type of cancer. Adenocarcinoma, one of the types of lung cancer, is more common in women than in men, and also more common in non-smokers. High-risk populations with gender-specific increase in lung cancer. So these people, women who are long-term or heavy smokers, women who are in poverty, women who've had late menopause or been on estrogen replacement while they smoked, and breast cancer survivors that are at a higher risk of developing lung cancer than male counterparts. This is a healthy lung, nice and pink. It's smooth where it should be smooth, a little bumpy where it should be bumpy so that the air exchange with the blood can occur. And then this is a smoker's lung, dark, black. And as we go through medical school and dissect people, you can really see the significance of that. And it really, other than the picture, is seeing it actually on a cadaver really has a big impact. They should, and on TV. The camel should show those. Breast cancer. So breast cancer is more common, but not as deadly as lung cancer for women. The most common cancer, other than skin cancer, and death rates have declined because of early detection, as well as a lot of advances in treatment for breast cancer. Risk factors that are not able to be controlled. So just being a female, females get breast cancer more often than males. It increases with age. Family history, especially those that have the BRCA1 or the BRCA2 cancer gene, and there is genetic testing for those genes now. A first period that occurred earlier than the age of 12, or menopause after the age of 55. Those are things that we can't control that impact our risk of breast cancer. There are other things that we can modify though. Alcohol. Drinking more than one alcoholic drink per day increases the risk of breast cancer, as does obesity, significant weight gain as an adult, different than being overweight your whole life. Recent use of oral contraceptives, those who never have children are at a higher risk, or if the first child's after the age of 35, and then current or recent use of hormone replacement therapy, especially if it's unopposed estrogen, not used commonly anymore. Warning signs for breast cancer: a new lump, something that feels different, looks different, so it changes in the skin, changes in the nipple, changes in the feel or contour of the breast. Those are things that are warning signs and should prompt you to seek medical attention, to have your doctor examine that area and determine any other diagnostics that need to be done. The recommendation is for women to start having mammograms every year, every 1 to 2 years, starting at the age of 40, unless there's a family history. If there's a family history of either breast cancer or ovarian cancer, that should occur, those screenings, mammograms should occur sooner. They should start sooner than the age of 40. And it takes about 1 to 4 years before a woman can actually feel a lump. So it's important to do a breast exam on a regular basis on yourself to detect anything, as well as to have your physician do the clinical breast exam when you see the doctor on a regular basis. But it does take an average of 1 to 4 years before the lump is large enough for someone to feel it. 68% of women 40 years and older have had a mammogram in the past 2 years. So there's room for improvement, definitely room for improvement there. Clinical breast exam is what the physician does, or nurse practitioner or PA would do, something done by the healthcare professional. And it should start occurring in women in their 20s. And it should be done at least every 3 years. A lot of doctors are doing it every year when they do their annual gynecologic exam. And then certainly for women after the age of 40, that should be done on an annual basis. A breast exam should be done by a woman themselves on a monthly basis is what it's recommended, and that should start in their 20s. Women should report any changes that they find or feel to their physician to see if anything else needs to be investigated. In terms of colorectal cancer, certainly this is a cancer that can affect men and women as the lung cancer, but there are some differences. It occurs in the GI system, in the colon or in the rectum primarily, and it starts with a polyp usually, and that's just a growth. Here's a picture of a little, just kind of like a little bump. So it's a growth that occurs within the colon, and over time, some of those polyps become cancer. Not all of them, but some of them can become cancer. So it's important to have a screening colonoscopy done on at the appropriate intervals based on history as well. Risk factors for women, family history of colon cancer, somebody who's over the age of 50, so colon cancer is something that increases with age as well. 93% of cases occur in people who are over the age of 50. Those with inflammatory bowel disease are at a higher risk, especially if that inflammatory bowel disease is not treated or not controlled. An inflammatory bowel disease is ulcerative colitis or Crohn's disease. It's not irritable bowel disease. They both can be abbreviated, well, this one can be abbreviated IBD, and irritable bowel disease can be abbreviated IBS. So this is just ulcerative colitis and Crohn's disease that can cause colorectal cancer. A diet that's high in fat and low in fiber can predispose people to colorectal cancer, as well as being obese, alcohol use, and lack of exercise. There's some symptoms, but these don't occur for everyone who has colon cancer. So these are things that would make you want to alert your healthcare provider that maybe some further investigation needs to be done. So if there's a change in your usual routine that you can't relate to any change in your dietary habits or activity level, if there's any bleeding, any discomfort, or an unexplained weight loss, those are kind of the red flags to us that we need to pursue and do some further diagnostics and investigation. The screenings for colorectal cancer begin at the age of 50. And it's either having a fecal occult blood test or a fecal immunochemical test, which is when you get a little card from the doctor and you take it home and you have your bowel movement and you put a little portion of it or a little smear of it with a little stick on the card and send it off to the lab. That's the fecal occult blood test. The fecal immunochemical test is after a bowel movement is done, then you use a paintbrush type device that you dip in the toilet bowl water, put it on that card and send it off to the lab. If that's the test that's being done, it has to be done on an annual basis because it's not as good as the other tests. Flexible sigmoidoscopy is done every 5 years because that doesn't see the entire colon. The colonoscopy sees a much greater portion of the colon, so that one can be done every 10 years, whereas the flexible sigmoidoscopy only sees the distal part of the colon, so that one would have to be done more frequently. Now, if there's a polyp that's found, depending on the type of polyp, the frequency of a colonoscopy or other tests can be much more frequent, or if there's a significant family history. So it can vary from 6 months, 1 year, 5 years, to 10 years, somewhere in between there based on your own individual history and individual circumstances. The proportion of women who've received colorectal cancer screening is improved. So we were at 37.7% in 2000, and by 2010 we were at 61.8%. So that's much better, especially because it's an inconvenient, unpleasant day of preparation mostly. The actual test itself is usually tolerated fairly well. It's the day before that takes you kind of out of commission. In terms of cervical cancer, risk factors for cervical cancer are people who've had their first sexual experience at a young age, people who have more than one sexual partner, or if their partner has more than one sexual partner. And the reason for that is because cervical cancer is highly related to HPV, or human papillomavirus, which is a sexually transmitted disease. So those who are at higher risk of getting that sexually transmitted disease are at higher risk of getting cervical cancer. Cigarette smoking also has an impact on increasing the risk of cervical cancer. It's estimated that about 50% of sexually active men and women will acquire that HPV, or human papilloma infection, at some point in their lives. By the age of 50, at least 80% of women will have acquired it. In the future, we'll see that to be a different number because now we're immunizing young adults and teenagers. Initially, women, young teenage girls were being immunized, and now men are as well, or young boys are being immunized against human papillomavirus. So we expect to see that number will decrease, and the incidence of cervical cancer will decrease. And we also expect to see the incidence of head and neck cancer to decrease. That's also related to the human papillomavirus. Signs and symptoms to watch out for cervical cancer: vaginal bleeding, especially after intercourse; irregular or postmenopausal bleeding. Irregular or postmenopausal bleeding is something that always should be brought to your healthcare provider's attention. It's never normal. It always needs to be investigated. Malodorous vaginal discharge is another sign or symptom. However, a lot of cervical cancer is asymptomatic. That's why it's very important for women to follow the screening recommendations. It's recommended that the initial PAP is done after someone becomes sexually active, or at the age of 21, whichever one comes first. And then there should be an annual exam thereafter, or for any symptoms. Now, there's varying opinions on when you can stop having a pelvic exam done and a pap smear done, and there's also varying opinions on the frequency of it. So some people say if you've had 3 normal ones, then you can do it every other year, or if you've had 3 normal ones, you can stop. There are different consensus recommendations by different organizations, different physician organizations on what's right. So really it just needs to be individualized to you, your risk factors, to make those decisions. 75% of women 18 and older have had a pap smear within the past 3 years. So that's good. That's better than our colorectal cancer screening rate and better than our breast cancer screening rate. However, 6 out of 10 people diagnosed with cervical cancer didn't have a pap smear. But that just shows us that if they have it, we're able to do intervention at a much earlier time. And even before cancer exists, but when there's a small change in the cell structure, be able to remove those cells to prevent cancer from occurring. This shows a decrease in mortality rate. So decrease in death rate was significant per 100,000 women for cervical cancer since the regular screening has come into play. All right, so that's cancer. We talked about heart disease, we talked about cancer. Now we're going to talk about stroke. Stroke can also be called a brain attack instead of a heart attack that you would call heart disease or heart disease. So a brain attack is when there's a blood flow cut off to the brain. So it's either caused by narrowing of that blood vessel, by plaque building up on all the sides of the blood vessel or in a certain part of it, and that becoming too narrow that blood can't pass through to part of the brain and then the brain dies. Or it can be caused by a clot coming from the heart or from one of the blood vessels in the neck that becomes loose and breaks off and travels to the brain and occludes that vessel, which again then cuts off the blood flow and that part of the brain dies. Or sometimes people have blood vessels that rupture, which is an aneurysm, but it can cause similar impact and similar effects. And some of the risk factors are similar to the plaque buildup or the thrombus or embolus. A stroke occurs every 45 seconds in the United States. That's a lot. It's a leading cause of long-term disability in the United States because people have significant deficits or can have significant deficits depending on which part of their brain is affected. And for every 5 deaths from stroke, 2 of them are in men and 3 are in women. So when women have a stroke, they tend to have, they're more likely to die, and they tend to have more morbidity and mortality from that stroke than our male counterparts. Risk factors that you can control: cholesterol, blood pressure, diabetes, obesity, physical inactivity, and smoking. There's that smoking again. There are some risk factors that we can't control. So aging, gender, race, some of your medical conditions, you can't control that you have them, but you may be able to make sure that they're controlled, that you're taking your medication, your numbers or whatever are as best as they can be. And then your family history, you can't necessarily impact either. If you think somebody's having a stroke, FAST is a simple test that's recommended for people to do, and it's very easy. The F stands for face, the A is for arms, S is for speech, and T is for time. So face, you're supposed to ask the patient to smile. If you notice that their smile isn't symmetric, one side is sagging, then that would potentially indicate they're having a stroke. You ask them to hold both of their arms forward. If one arm drifts down, they're not able to hold them steady, then that would be a potential sign of a stroke. And then you ask them to repeat a sentence. So if they can't repeat you, but they can talk, or if they're slurring their words, that would also be a sign of a potential stroke. And then the T is for time, because time is brain. So if you see any of those things, you want to call 911 or go to the emergency room as quickly as possible. So that's stroke. And now this is something that doesn't necessarily cause death, though it could, but we're going to talk a little bit about osteoporosis. So the graph here shows the incidence of osteoporosis fracture is really high and compared to the incidence of heart attack, stroke, and breast cancer. So osteoporosis doesn't necessarily, it's not one of the leading causes of mortality, but it does have a significant impact on women and women's health. 50% of women over the age of 50 will suffer an osteoporotic fracture within their lifetime. So that's half of everybody here. This is one of the reasons for it. Your peak bone mass is around the age of 30, late 20s to early 30s, and thereafter you lose bone just as part of the normal aging process at a rate of about 0.3% per year until menopause. Once you hit menopause, then bone loss accelerates to about 2% per year. So that's a significant change. So it's important for young people to try and get that peak bone mass as high as possible. So we want to make sure that our children and grandchildren are eating enough, getting enough dietary intake, we're physically active, doing all of those right things to make that peak bone mass as high as possible. And then we need to see what other interventions we can do in our lives to try and slow down that rate of loss of bone. The recommendations for screening for osteoporosis are to screen women starting at the age of 65, and that's done every 2 years by a DEXA scan. There are like a foot scan that sometimes you see at health fairs or a hand scan. Those ones aren't as good as the one that you would get done in the doctor's office or at a hospital that looks at your hips and your spine. So you want to make sure you get that one done and not just the screening test that would look at your foot or your hand. Women who have risk factors for osteoporosis, they start getting screened earlier at the age of 60. And risk factors would be maybe some of the medications they're on, maybe all the women in their family have fallen and broke a hip over time, maybe they started to lose height. Those things would tip us off that we need to check for osteoporosis earlier than the age of 65. Depression. Depression is more common in women, about 2 times it occurs at about 2 times as often as that in men. Women attempt suicide 2 times the amount of men. However, men are more likely to die from their suicide attempt because of the method at which that attempt occurs. So men are more violent with their attempts than women. Less than 50% of women with clinical depression actually seek medical attention or care for it. So there's a lot of women in the community who are trying to manage on their own or with their own support system when they're meeting the definition of clinical depression, and maybe there's other things that we can offer to help them. And there's certainly a link between depression and other illnesses. So people who are depressed aren't able to control their diabetes as well. They have a difficult time maintaining their weight. Maybe they don't take their medications as regularly as they should, or maybe they're drinking more alcohol than what would be recommended. So all of those things can be linked to depression and have a significant impact on health. So we need to know the risks, and then we need to see what we can do to change for the future so that we can be as healthy as possible. This pie chart shows the different factors that contribute to mortality, and the part to look at is that big red section. 50% of the things that impact our mortality are behavior and lifestyle. So those are things that we can do. The small, very small impact that I have as a physician, medical care is 10%, but a lot of the rest of the things are each individual person, each individual patient, things that you can do. We can't change our genes, but we can change our behavior and we can change our lifestyle. So it's important to be aware of different things. So for cholesterol, this shows the desirable range of total cholesterol, 200 or less for the general public. People who have healthy or who have heart disease or who have diabetes, that number is going to be lower. But for somebody who doesn't have those other medical problems, 200 would be your desired number. For bad cholesterol, you want it to be less than 100. And the good cholesterol, you want to be high. You want that to be higher than 50. It's very hard for women to actually get that number high. That number is raised by exercise. So the more exercise and physical activity you do, the higher the HDL will be. The better your diet is, the lower your LDL will be. And the combination of the physical activity and diet are going to make the total cholesterol in that optimal or desirable range. This shows the plaque buildup of cholesterol, and then how it would block the blood vessel. We screen women starting at the age of 20 every 5 years for high cholesterol. Once someone's diagnosed with high cholesterol, or if they have other risk factors for high cholesterol, then that screening's done much more frequently than 5 years. But starting at the age of 20, we screen people for cholesterol. And then we screen everybody who's 45 and older on an annual basis. For blood pressure, and their new guidelines came out this summer for blood pressure. There's always changing in guidelines and research. The new guidelines that came out this summer were a consensus statement for blood pressure, and it was much more liberal than prior. The numbers I have here are more of what the previous recommendations were. So the goal really is, the prior goal was 120 over 80 was what was considered good. Between 120 and 140 and 80 and 90 was where we were starting to be worried, or maybe treatment would be started, and certainly over 140 over 90 medications would be started. And again, this is people without other medical conditions. Since this summer, those guidelines have been changed, that it's much more liberal, especially in older patients. However, there's been a lot of response to that guideline update that nobody thinks it's good. So really, most physicians haven't changed their practice, and these are still the numbers we're looking at. But it does need to be individualized to each patient. So somebody might feel lousy at 130 over 85. They might feel dizzy and nauseous and not be able to function. But if we let them be 140 over 88 or something, they might feel good. So it has to be individualized to each particular patient. And more will be coming about where we go. But I expect things will go back to how they used to be for the recommendations. Hypertension occurs 1 in 4 women. There's less complications from hypertension in women than there are in men, so that's one thing that we have going for us. And it's important to screen for hypertension in adults at the age of 18 on an annual basis. And actually, children are screened starting at the age of 3 for blood pressure. Hypertension is increasing in the United States. So it went from 23.6% to 27.7% from 2000 to 2010. And as we have all of our lifestyle and obesity epidemic, we expect that that's going to continue to increase until we're able to make some changes there. In terms of blood sugar, so another risk factor for all of these other diseases, and certainly a risk factor for diabetes. Diabetes is when your body doesn't produce enough insulin and it doesn't respond well enough to the insulin that it does produce. So it's not sensitive to the insulin it makes, and it doesn't make enough insulin to process all of the food and drinks that you're putting into it. Incidence is certainly on the rise for that. In 2000, 5% of women were diagnosed with diabetes. 2010, it was up to 8%. And if we continue to grow at that same rate, we expect it's going to be 1 in 3 adults by the year 2050. And there's significant impacts from diabetes, heart disease, strokes, kidney disease, vision, peripheral neuropathy, amputations, all of those things are potential after effects of diabetes or uncontrolled diabetes. So it's important to do what we can to prevent it, and then certainly to take charge of that disease if you do have it. Make sure that your numbers are at goal. The risk of heart disease is greater for women with diabetes than for men, and there's a lower survival rate and poorer quality of life following a heart attack, like I mentioned earlier. And the risk of blindness is greater in women than that of men who have diabetes, even at the same control rate or A1C. So we screen for type 2 diabetes in asymptomatic adults with hypertension or in asymptomatic adults with high cholesterol. So people with high blood pressure and high cholesterol should get screened for diabetes on a regular basis, or if we have any other suspicion, then we would screen. And it's done by blood check, by a blood draw generally, either on just a regular blood glucose level or by hemoglobin A1C that tells us your control over the last 90 days. In terms of weight, obesity is the second leading cause of unnecessary deaths in the United States, and its incidence is on the rise in women as well. So in 2010, 26.4% of women were considered obese. In 2000, it was under 20%, 19.8%. So again, this is an area where we can make some improvement in the lifestyle choices we're making. And really, it's a balancing act. It's a balancing act of the calories in from food and beverages to the calories out, the body's normal required functions, as well as the physical activity that's done. There's a lot of different diseases that are affected by weight: heart disease, diabetes, different types of cancer, blood pressure, cholesterol, stroke, as well as gallbladder disease, liver disease, sleep apnea, some other respiratory problems, arthritis. A lot of things are affected by obesity. All right, so we need to lower our risk of all of these things by making sure we're following a healthy diet, exercising regularly, controlling our weight, practicing good health habits, managing the risks that we're taking, wearing seatbelts, as well as managing our stress so that we're able to take good care of our health and take good care of our families. So we're going to train to maintain. The average woman loses 5 pounds of muscle every decade, starting at the age of 20. And that adds about 10 pounds of fat every decade because muscle burns more calories than fat. So as you lose your muscle mass, if you do nothing different, you're going to add 10 pounds of fat every decade. It's not very exciting. And this would reduce your muscle mass by a third by the age of 50 because it starts at the age of 20. Strength loss is 12 to 14% per decade after the age of 50. So that makes us more susceptible to all of these diseases, as well as falls, poor quality of life, all of those kinds of things. You can have half the original muscle tissue by 60 with a higher percentage of body fat. That also changes the way your medications work. So some of the medications are distributed throughout the fat in your body. So when you're 20 versus when you're 80, if you have a higher amount of fat in your body when you're 80, we have to dose your medications differently because you're getting a higher concentration than you would if you were a 20-year-old with a larger muscle mass. Too low of a muscle mass increases the risk of lots of different medical problems: back pain, heart disease, falls, bone mass, diabetes, and many others. This doesn't count as exercise. The dog's getting exercise, but the driver is not, so that doesn't count. And the studies show in surveying the public, the studies show about 30% of women 18 and older engage in regular leisure time activity, physical activity, 30%, so that's not enough. Certainly other people are able to participate in physical activity for exercise in the form of exercise that may not be, and it's different. So some people may be runners or bikers, interested in doing those kinds of things, but other people might enjoy yoga class. You know, it can be anything, a wide variety of things. It doesn't even necessarily have to be a structured class or a structured time, but take the stairs if you can, rather than the elevator. Park a little further away in the parking lot if you can. And if you're somebody who's not able to ambulate, there's chair exercises that can be done as well. There's different recommendations for this by different groups. The sports medicine folks, they want you to exercise all the time because they're sports medicine people. The geriatricians, you know, we're like, let's try and do 30 minutes a day most days of the week, and we're happy with that. We're happy with what you're able to accomplish. Also need to follow a healthy diet. The food pyramid has changed shape. We're trying to put a lot more emphasis on fruits and vegetables, proteins, less emphasis on fats, oils, and carbohydrates. You need to have enough dairy for your calcium and vitamin D, but you have to be cautious on the type of dairy that you're taking in so that it's not too high in fat. And then there's other things certainly that have calcium and vitamin D that aren't milk and ice cream or cheese. So we have to look at different options in our diet as well. Balanced diet reduces the risk of high blood pressure, heart disease, stroke, diabetes, obesity, cancer, diverticulitis, a lot of other things, too many really to actually include on a slide. Tobacco. And we talked about tobacco a bit. The proportion of women who smoke has declined. More than 1 in 5 women smoked in the year 2000, and now it's 1 in 6. So that's an improvement. We'll take that extra person who's not smoking and be happy for them and support that. Smoking is directly responsible for 80% of the lung cancer deaths, and female smokers are nearly 13 times more likely to die from COPD than men. So women who smoke have a much more significant impact on their health than men who smoke in forms of cancer as well as COPD. It also increases the risk of other cancers and coronary disease, and postmenopausal women who smoke have lower bone density than those who didn't smoke. So we shouldn't smoke. Alcohol, there's different opinions on alcohol as well. 60% of US women have had at least 1 drink in the past year. 1 drink in a whole year's time isn't that significant, but among women who did drink, 13% had 7 drinks per week. 14% had 5 or more drinks at least one day of that year, so that would be considered a binge drinker. Moderate drinking for women is no more than 1 drink per day, because women tend to be smaller in stature than the male counterparts. So there's a lot of people who favor a glass of wine a day and its health benefits, but there are also negative effects on health from too much alcohol or the wrong type of alcohol. So accidents, injuries, blood pressure, stroke, violence potentially, suicide potentially, memory loss, and certain types of cancers can all be related to alcohol use in women. This is risky behavior, and this basically just shows that our male counterparts are more higher risk takers than females. So some of the questions, this was a survey given to patients, some of the questions on here are about smoking and drinking, but other ones are, do you drive over the speed limit? Do you break traffic laws? Do you gamble? Do you engage in risky recreational activities like skydiving, things like that? So men are more likely to take on those risky behaviors than women, which is probably what we would assume. It's important to manage our stress, and not by drinking or gambling or skydiving, but doing other things that are healthy. So we need to pay attention to our mental health, make sure you're getting enough sleep, surround yourself with a positive support group. The quote here says, "The way you treat yourself sets the standard for others." So treat yourself well, make sure you're taking care of your own health so that others take care of you and you can take care of them. See the doctor on a regular basis. I'm a doctor. I want my patients to come and see me so I can help you, help partner with you so that you can be healthy. So you need regular checkups. You need to manage your chronic diseases. Most of the time, you're taking care of your chronic diseases yourself. You're managing your diabetes. You're managing your high cholesterol. I only see you for 15 minutes a couple times a year. So really, I need to provide you with the tools, but then it's up to you to be able to do all of that. And then we also need to make sure that preventative screening things are being done on the appropriate interval. Only 8% of adults adhere to regular healthcare schedules. So they're canceling appointments, they're not taking their medications, they're not following the diet rules. Only 8% actually follow all the rules. So that's 92% of people who aren't. Women, more than men, actually limit their doctor visits if they are in a financial challenge. So especially in the last little bit of time, over the last 5 years or so, women had been skipping doctor's appointments because they couldn't afford their copay, or they were not filling their prescriptions because they couldn't afford it. Hopefully a lot of those things are changing as the economy is changing and access to healthcare is changing based on all of the policies, changes, and things that are occurring. 50% of all medications are taken inappropriately. That may be because people aren't filling their prescription, they're choosing not to take it, they don't want to take it, they don't like how it makes them feel, or maybe they're not taking their thyroid pill by itself so it can work appropriately and waiting to take their other medications 30 minutes later. So sometimes it's education that we need to provide. Sometimes there's other factors or barriers that we need to be aware of so we can help people to stay healthy and well. Preventative screenings need to be individualized. I had talked about the recommended intervals and the ages that we start all of the screenings. I didn't talk about when we stop them. And that's a common thing that I encounter with my geriatric population. But mostly we look at the individual person and see, are they healthy? Are they well? Are they active? If they are, and they want to know if they have a disease and they would want to pursue treatment if they have cancer or something like that, then we're going to do the screening test. If there's somebody who is in a nursing home, they have limited interaction with their family, they have limited interaction with their staff, they're very frail, they're in and out of the hospital, maybe we're not going to do a mammogram in that patient. So it really needs to be individualized regardless of age. It's more based on the person's overall health and well-being. So it's up to you to make a difference in your health. And the things to do to make a change, so you have to think about it, and then you have to stop thinking about it and start doing something. So you have to figure out what that action plan is going to be, and then you need to try it. And a lot of times when we try to do something different to improve upon ourselves, to improve our health, or to improve anything about ourselves and in our lives, we might have some fallbacks. So we need to surround ourselves with support, with the right tools so we can be successful. And then once you get into a habit of doing that, you maintain that for life. It's something that, you don't feel well if you don't get your regular exercise in this week. So you're going to make sure that you do all of those things. And it's never too late to start. But wear a helmet. All right, I'll take questions.
I'd really like to make a comment.
Sure.
A friend of mine that was a hunter fell out of a tree stand, banged himself all up, took him to the hospital. He had never been well after that, always had problems. His wife wound up being woken up in the middle of the night, and she had been after him for a long time. Let's go to the doctor, let's go to the doctor. And no, I'm all right. Never really got better. Finally, when she got poked, she got scared, took him to the hospital, he never got out. She's on a campaign now that you yourself cannot be your own care decider. And she's saying to everyone else, you have to make that decision for your husband. Your husband has to make that decision for you. You do it in advance and you don't back down. This is something that really could save a lot of lives.
Yeah.
I told my daughter that story, and I wound up with a bad cough, and I said, no, I'm all right, I'm all right. You know how guys are, macho, they're gonna need it. So she says, no, you're gonna go to the doctor. Oh, no, Kathleen, I'm all right. No, you're gonna go to the doctor. So I finally, just to get her off my back, after telling this story, I go to the doctor, he takes an x-ray, I was in the process of coming down with pneumonia. So if she hadn't, and I had waited 2 more weeks, I would have had a major problem.
Yeah. Thank you for sharing that. Thank you.
Can I ask my question? Okay, there you go. Thanks. Well, of course, I've had mammograms down through the years. However, in the last few years, I've learned about thermography and the attributes, and I see a lot of advantages, and I really don't understand why they aren't used more often. Do you know anything about mammogram, or no, you do, about thermography?
We don't have a lot of access to it locally. So there's other things besides mammograms that can be done. You can also do breast MRIs, but you have to make sure, there's other things that need to be in place. So the equipment has to be available, and then the people need to be trained in the ability to read it. I expect those things will be becoming more commonplace in the future, because even mammography's ability to detect cancer is not as specific and sensitive as we would like it to be.
Well, their literature convinced me that they found cancer sooner with thermography. It's a camera, nothing touches your body.
It's much more comfortable.
Yes. And however, you do have to pay for it yourself.
For now.
Yeah.
For now. And we'll see what happens in the future, hopefully. As they do more research and find more good evidence to support its use, it'll become commonplace.
I hope so.
Yeah.
We'll reverse this. Yeah, okay. I understand that the screening guidelines for women for both mammography and pelvic exams says that there's an age limit after which you need not do that screening. And I'm curious as to whether that is a matter of science, and if so, what is the science?
Whenever screening recommendations are created, it's based on how much does the test cost, what's the risk to the patient to have the test done, and how often is the disease detected accurately. So it's kind of a balance of those things. When they make cutoffs or stop points for or recommendations for PAPs and for mammograms, it's based on the likelihood of if breast cancer was detected at a certain age, and we know that your life expectancy is a certain number of years based on actuarial data, not on you as an individual, would your cancer detection at whatever age that is and treatment, would that be what causes your death by that age? So it's based on dollars and numbers.
Right.
Yeah.
Okay.
I would like to know, does insurance play a part in what you might recommend to one of your patients? If you know that somebody has not very good insurance, do you say to them, you know, I don't think it's going to pay for this, would you still like to have it? Or do you say to them, which was said to me, we probably should do this, but your insurance won't pay for it? And then they didn't do it. And then I walked away and changed doctors. But how much does insurance influence you on what tests you prescribe for your patients?
I think that insurance should not influence us on what tests that we're recommending for our patients, because we should treat our patients the same regardless of their ability to pay or regardless of their insurance coverage. However, it does play a role in maybe the patient agreeing to have that test done. So I make the recommendations based on medicine, science, my clinical opinion of the patient, and then I discuss it with the patient. If there's a concern that maybe the insurance wouldn't cover a test, then we talk about that. What's the alternative test? What would be the difference? You know, what would we maybe be missing by not doing the best test? And then I work with the patient to make that decision. Our health system is very good at supporting patients' needs and taking care of patients without, regardless of their ability to pay. So we have a program that if someone's insurance isn't going to cover something, or they need, help with their copay, that kind of thing, that we're able to work with them on that. And that's been very beneficial for the organization that I work for in our health system. But I think we should always recommend what science, evidence, clinical impression says. There is a variation of what insurances will pay for and what they won't, and oftentimes we have to appeal and fight. Sometimes it takes longer to get it approved than we would like, but we always fight.
Okay.
Even when it takes me calling the insurance company.
Okay. I'd just like to feel confident that that decision would be put back onto me, whether I wanted it. But fortunately, when he said to me, we probably should do this, but your insurance won't pay for it, that was the end of that relationship.
Yeah.
But I just had hoped that most doctors would let that decision be made
Be the
by
patient's.
the patient.
Yeah. With the information from us, what's the difference between the different types of tests? Same with medications, because every insurance company has different formulary and what the copay would be, what's covered from medications, and not all medications are the same, even if they're in the same class. So it's a similar conversation where this is the best medicine for you, this is why. Your copay might be $25 instead of $10. You make the decision. Here's the reasons why, or what can we do to help support you in that?
Okay, thank you.
Hi, thank you so much. 15 years ago, my younger sister was diagnosed with colon cancer. She was 35, and it's been a great resolve. But she was told it was probably hemorrhoids. And I think, speaking to a group of women, sometimes we need to feel empowered that we can meet the challenge of a diagnosis that we don't feel is right or would like to follow up on. So I think it's important in these presentations to include empowerment and really making us feel like we can move forward. We know our bodies, and we need to make sure that we get the results we need.
Yeah.
That's all.
Thank you.
I have two things. A comment on the woman about not getting the test because of insurance. Recently, I had an episode where I needed a CAT scan to diagnose, and the insurance company wouldn't give the full CAT scan until my doctor argued for 45 minutes and then got it. And the second part of it is what showed what I had wrong with me. So I was glad that she fought for me.
Yeah.
And the second one, I don't know if you're interchanging the term clinical depression and depression, and if there is a difference between the two, what is it?
I think I'm probably just interchanging the term.
No, not you in particular. I hear it all the time. Some people will say depression, and some people say it's a clinical depression. And I didn't know if there was indeed a difference.
There's diagnostic criteria for depression, just like there are for other diseases. Depression's a little tougher because it's not that you can do a blood test or a CAT scan to get the answer. So it's a constellation of symptoms that makes that diagnosis. But I don't think that there's any difference. No, I think it's just that we as a community and healthcare professionals, we interchange those words.
Thank you, Dr. Hansen. We need to wrap the